Hi, good morning, everyone. My name is Lauren Heyda. I'm a fourth-year research resident at Walter Reed, and I'm going to talk about simple versus complex biliary procedures performed at a resource-limited military treatment facility. Sorry. So I have no disclosures for the purposes of this presentation. All views are my own. So common bile duct stones are present in up to 15% of patients undergoing cholecystectomy. Contemporary management includes pre- or post-operative ERCP or surgical common bile duct exploration at the time of cholecystectomy. Over time, however, there's been a dramatic decrease in the rate of common bile duct exposure, an increase in ERCP for treatment of choledocholithiasis. Over a 15-year period, common bile duct exploration has decreased from about 40% to 9%, with only about 3% of that being a laparoscopic exploration. Recently, there's been a pretty significant resurgence in academic interest in laparoscopic common bile duct exposure. There's been many large-scale reviews and meta-analyses evaluating common bile duct exploration versus ERCP. And even just if you were to type in keywords into PubMed, you can see by keyword, the great increase in recent articles and publications. So in comparing common bile duct exploration and ERCP for the management of choledocholithiasis, there's been found to be no difference in morbidity, mortality, or rate of retained stones. There's also no difference in surgical success rate, postoperative complications, or conversion to open. And common duct exploration during cholecystectomy has been associated with lower healthcare costs, decreased length of stay, decreased medical resource utilization, the lack of need to get additional medical teams involved in patient care, and a decreased number of anesthesia exposures to the patients. However, despite all these benefits, there's been a large number of barriers to implementing common bile duct explorations. Most commonly, it's attributed to surgeon comfort and overall lack of technical training. It's estimated that about 70 to 80% of surgeons would elect to perform an ERCP with cholecystectomy due to lack of training and experience. And it's estimated that a learning curve for laparoscopic common duct exploration is about 60 cases. Additionally, advanced endoscopy is readily available at most tertiary centers, making it very accessible for patients to undergo ERCP. And an increased ERCP utilization has led to a decrease in surgical resident case exposure to complex biliary procedures. Over time, despite increases in biliary disease in the US, general surgery residents have increased in their number of biliary procedures performed. Significantly, they've increased in their laparoscopic cholecystectomies, however, decreased in the number of open procedures performed. But despite this decrease, the number of common bile duct explorations, laparoscopic duct explorations, and choledochoenteric anastomoses has decreased over since 1999 to 2017. This is problematic, especially for the military practice, as institutions without advanced endoscopy and with limited transfer options, surgical common bile duct exploration is the only option for management of choledocholithiasis. This suggests that an advanced biliary skill set might be important, particularly for a military surgeon who could be placed in a resource-limited hospital. Specifically, we looked at Navy Hospital Guam, who has no ERCP capabilities and very limited MRCP capabilities. And as you can see on the map, it's quite isolated, so transfer out of Guam is very challenging as the nearest hospital is Tripler, which is an 8-hour flight away. So we sought to examine the case volume of biliary procedures at Guam and their associated patient outcomes, and then compare this to that at Walter Reed, a tertiary MTF, to evaluate for the differences in practice volume. So we performed a data query using diagnosis and procedure keywords to identify all patients who underwent a biliary procedure for biliary pathology, excluding oncologic, at Guam from December 2010 to May 2023. Procedures we specifically looked at were cholecystectomy, IOC, and common bile duct exploration. Secondary outcomes were lap versus open procedure, procedure time, length of stay, ICU admission, post-op antibiotics, and disposition. We then compared that data to that at Walter Reed from September 2015 to December 2019. Overall, 454 patients were observed over this time frame at Guam. About 50% of these patients underwent cholecystectomy alone, 36% underwent cholecystectomy with IOC, and 13% underwent IOC with common bile duct exploration. Those patients who underwent IOC with duct exploration were at a significantly higher risk of first initially undergoing an open procedure and then converting to an open procedure. We also looked at length of stay, procedure length, ICU admission, and risk of needing postoperative antibiotics. Unsurprisingly, the procedure length was significantly longer in those patients who underwent IOC and those with IOC and duct exploration, but also they had a significantly longer length of stay, risk of ICU admission, and need for antibiotics. There was no statistically significant difference in disposition, whether patients were discharged home, transferred to an acute care facility, transferred to a different MTF, or mortality. So then looking at Walter Reed versus Guam from September 2015 to December 2019, unsurprisingly, Walter Reed performed significantly more cholecystectomies. However, over that time frame, they performed 0 common bile duct explorations, and Guam performed about 6%. Additionally, the rate of IOC at Walter Reed was about 10%, whereas at Guam it was about 36%. So in conclusion, complex biliary procedures were more commonly performed at Guam compared to Walter Reed. The addition of cholangiography and duct exploration was associated with a significant increase in all outcomes examined, and deliberate training in advanced biliary procedures may be valuable for the military surgeon, given our increased potential and risk for practicing in a resource-limited environment. Any questions?